Yeah, so David,
Yes, Joseph.
another case for you today. And as usual, we start with an opening one liner. So this was a young male, 21 years old male, who presented to the hospital that I was working with a 1 week history of abdominal pain and 3 days history of fever.
Okay. Right. Yeah, so before I start, I think I should start with my disclaimer that this is as I'm going to discuss this case, it's real time thinking, and therefore I believe I'll be making a lot of mistakes and errors. So I would encourage everyone not to take my words for facts, but rather to go and fact check everything that I'll say in your own time in order to make sure that we improve our clinical reasoning every day. Yeah, so abdominal pain for 1 week and then fever for 3 days. So both of them are very broad complaints, and therefore, with what we have here, I think I won't spend a lot of time discussing this because if you talk of abdominal pain, you have so many differentials. So what will help you narrow down is if you get some few uh, pivotal points that can help you narrow down your differential. And then, but if I try to combine fever, I mean the abdominal pain for 1 week and then fever for 3 days, uh, they could be completely unrelated complaints. That means, one might have started independent of the other, or they could be explaining the same pathological process going on, meaning they are overlapping at some point. And of course, there is a huge overlap between abdominal pain and fever. So uh, I would be convinced to discuss them as representing the same thing going on in the same patient, but I think they could be different pathologies. So uh, I mean, I won't even start mentioning differentials at this point in time because abdominal pain is a very broad complaint. So if I start mentioning, I'll just be listing differentials, but with no direction. And then fever again, same way, a very broad complaint, and therefore it's until I get a few pivotal points that will help me narrow down. That's when I can start discussing differentials. So just more details.
Okay, thank you. And thank you for being so humble. I don't think if we should fact check everything you say, but most of the things there are right. So yes, let's move to the HPI. And so this young man was previous as well, and about 1 week ago, he started to experience upper abdominal pain, which was gradual in onset and was increasing in severity over this past week. It was non-radiating. It was associated with nausea, no vomiting, no diarrhea, no constipation. It is not related to meal intake. And about the fever, it started 3 days ago. It was on and off, and it was associated with chills, night sweats, and on and off headaches. But he denies cough, shortness of breath, weight loss, nasal congestion, sore throat, skin rash, or itching. That's the end of the HPI.
Okay. Yeah, I see we have a very difficult journey today. All right. So abdominal pain for 1 week. So yeah, as I said earlier, with a very broad complaint like abdominal pain, you need something uh, that can help you narrow down. So when we talk of abdominal pain, the location of that abdominal pain is very important. So yeah, maybe now just for, if I can if I can go fraud a little, just for some little learning, is most of the time when I think about abdominal pain, the way I approach is it. The way I approach it is I think in terms of regions. So if I hear up abdominal pain, I mean, it would be more helpful to talk in terms of the 9 regions. So if I hear epigastric pain, the differentials that I prioritize will be very different from when I hear that the abdominal pain is suprapubic, for example, uh, or is lumbar or iliac. So I think in terms of anatomical regions. So this abdominal pain here is upper abdominal pain. Now, not very specific whether it's upper central or in other areas, and therefore I'll just think of all the possibilities around the epigastric area and around both hypochondriac regions, and therefore something like peptic ulcer disease, something like pancreatitis, and given the time cause acute pancreatitis, cholecystitis, acute hepatitis, all these are a possibility. So the abdominal pain is up, and that's why I'm thinking of those. I prioritize those as opposed to other causes which will present with abdominal pain, which will be lower in location. And that abdominal pain was gradual in onset and increasing in severity, non-radiating. We so from this HPI, I do not pick the nature of the pain. When we talk of pain, the nature is also very important. So, Joseph, if you mind telling me, I believe I haven't missed it anywhere. So if you don't mind telling me the nature of that abdominal pain, it would be helpful.
Yeah, it was dull pain.
Okay. So dull aching, and then it was associated with nausea, but no vomiting, diarrhea, or constipation, and no relationship to food intake.
Yeah.
Yes, so abdominal pain that has a relationship with food intake. You talk of things like peptic ulcer disease will have an association with food intake, either worsening with meals or being relieved by a meal, depending on whether it's gastric or duodenal. And then pain of cholelithiasis can also be related to meals. So when someone takes a fatty meal, the pain can worsen. So this pain doesn't worsen with food intake, no relationship with food intake. So that's about the abdominal pain. Those are some of the possibilities that I have, solely based on the location of that abdominal pain. And then we go to the fever, that the patient developed on and off fevers associated with chills, night sweats, and on and off headaches. Uh, but no cough, no shortness of breath, no weight loss, nasal congestion, sore throat, or skin rash or itching. So again, when we talk of fever, when I think of fever, I think of I think I've talked about fever. Uh, I've discussed about fever previously in one of the clinical notes that we did, and I mentioned one mnemonic that I use is IMED. So I think of infection, I think of malignancies, I think of autoimmune disease, I think of drugs and endocrine causes when I think of fever. So this particular patient presented with fever associated with chills, night sweats. And then when you talk of fever now, of course, I mean, based on base rate, we'll definitely prioritize an infection unless we get some pointers that are leading us in another direction. So, but when we think of infections now, we have a lot of differentials when we talk of fever. So this abdominal pain, this fever came a number of days after the patient presented with abdominal pain. So it could be a possibility that we are dealing with an infection in the gastrointestinal system. That is just one huge possibility, but then it could be something completely different. Because when I talk of fever, I if I'm taking history from a patient with fever, due to the fact that fever is a very broad complaint, I try to ask about symptoms that could direct me to a certain focus that is telling me if I'm thinking of an infection, this could be a possibility. This patient doesn't have any signals in the respiratory system. There is no cough or shortness of breath, no nasal congestion, and no sore throat. So it's a huge possibility that we are possibly not dealing with something in the respiratory system. So that's one of the major foci when you talk of an infection presenting with fever. Another one is the genitourinary system. So painful urination, urinary frequency, flank pain, especially because a lower urinary tract infection doesn't present with fever commonly, but then an upper urinary tract infection like pyelonephritis can present with fever. And then the other one is the skin. So a skin rash, any ulcers, we do not see that in this patient. So at this point in time, of course, I haven't made much progress, but a huge hypothesis that I have is they could be totally unrelated problems, but I'm considering a huge possibility that they are related. And we are probably dealing with an infection or inflammation in general that is going on in the gastrointestinal system, presenting with fever as a constitutional symptom. But I believe as we go on uh, and dive deep into the history and physical examination and maybe investigations, I may be able to down and know what's going on.
Okay, thank you. So we move on and review of other system, cardiovascular system, no palpitation, no volume swelling, no orthopnea or PND, the neural system, no focal weakness, no numbness, no altered mentation, musculoskeletal, no joint pain or swelling, no muscle pain, genitourinary, no dysuria. The past medical and past surgical history were non-contributory in this patient. He was not on any meds, and family social history, he's a college student, doesn't drink alcohol, lifelong non-smoker, doesn't use illicit drug. He was sexually active with one female partner to whom he reports inconsistent use of protection. There is no known illnesses to his first degree relatives, that all of them are still alive. Back to you, brother.
Okay, so the review of systems is unremarkable.
Sure.
Yeah, the review of systems unremarkable, so we haven't made much progress based on that. Now coming to the past medical history, again unremarkable. This patient is not on any medications. So I mentioned in my I made him mnemonic, I mentioned that drugs are one cause of fever. The patient is not on any medication, so we can take that off the list. And then this patient doesn't drink alcohol. So one of the things, if we are talking, if we find a point of overlap between the abdominal pain and the fever, I talked about a possibility of infections and many other things. But then one thing that I would think about is the patient is presenting with upper abdominal pain and then presenting with fever. One possibility could be acute pancreatitis, but then this 21-year-old male is not on any medications. He doesn't take alcohol. So So alcohol is one of the major risk factors for acute pancreatitis. Although yes, another one is gallstones, and I think gallstones could be a more common risk factor than alcohol. But then the fact that this patient does not drink, I mean, yes, to some extent it reduces our possibility that we are dealing with acute pancreatitis. But I'll just throw it in as one of my differentials. And then the patient doesn't smoke, doesn't use any illicit drugs. The sexual history, this patient who is presenting with abdominal pain and fever, uh, I do not see it to be contributing very much at this point in time. It could be, but I do not see a contribution. Maybe if I get some signals later, I might need need some more details on his sexual habits. Yeah, so basically, based on the review of systems, based on the family social history, as well as the past medical, past surgical, and medical history, they do not help me make much progress, but rather remove a couple of things as possibilities. So let's just proceed.
Okay. So we move on to the general exam. Ooh, let me admit someone. Okay. We move on to the general exam. So he was alert and oriented to time, people, place, and event. He was febrile. There was no conjunctival para. There was scleral jaundice. There was no lymphadenopathy. He had dry mucous membranes, no oral thrush or exudates, no lower limb edema. The skin was without any rash. Her vital signs included the blood pressure of 122/78, a pulse rate of 88, respiratory rate 16, temperature of 39.3 degrees centigrade. That was temporal, yes, the temporal temperature. It was saturating at 99 on room air. The abdominal exam, he had a normal abdominal contour which moved with respiration. He had a tender right upper quadrant with a negative Murphy's. His liver and spleen were non-palpable. He had a tympanic percussion knot and normal bowel sounds. The cardiac exam, chest exam, neuro exam were all unremarkable.
Okay. I think the exam, starting with the general exam and then the systemic exam, they helped me make a little progress. So this patient is febrile with a temperature of 39.3. The patient is febrile, and then there is scleral jaundice. So, uh, and then coming to the systemic examination, the patient has right upper quadrant pain, a negative Murphy sign. If I combine these things, the patient is presenting with abdominal pain. It was up abdominal pain initially. We didn't have many details on the location of the abdominal pain, and then later on the patient presents with a fever. And then we come to physical examination. The patient is febrile, has jaundice, and on systemic examination, he has right upper quadrant pain. Otherwise, we do not have any other findings. So this raises, my biggest or the differential that I'm prioritizing at this point is we are dealing with an acute hepatitis. We are dealing with an acute hepatitis. Why am I thinking of that? The patient is presenting with abdominal pain. Initially, we were told it's upper abdominal pain, and then physical exam is telling us he has right upper quadrant tenderness. So that's in the right hypochondriac region, I'm assuming. And then the patient has jaundice. The patient has jaundice. And uh, and is febrile. So a huge possibility that we are dealing with acute hepatitis. But then if it's not acute hepatitis, what else would it be? Because that's just one differential. So the other possibility is, I mean, that's the biggest possibility, that we are dealing with a local process. We are dealing with a local process within the liver. So an acute hepatitis. At this point, no discussion on what exactly is causing the hepatitis, because it could be anything. So I'll come to that later. But then if it's not acute hepatitis, so yes, it could be a systemic process. It could be a systemic process, but with the liver as one of the organ systems that are involved. So for example, this patient has fever. The patient could be having something like malaria. And then, yes, I mean, with malaria, commonly we see that if the patient presents with jaundice, the jaundice is because of hemolysis rather than the liver being affected. So if we talk of something like malaria, we wouldn't really expect the right upper quadrant pain. But there are other possibilities if I think of other infections that can present with hepatitis. So, for example, leptospirosis can present with hepatitis. So you can have a similar presentation, fever, gastrointestinal symptoms like that with hepatitis, leptospirosis. And then you also have some viral hemorrhagic fevers that can present. I mean, gastrointestinal symptoms are not very common with those viral hemorrhagic fevers, but and by gastrointestinal symptoms, I am talking about the vomiting and other things, but abdominal pain, especially right upper quadrant pain, is a possibility. For example, something like yellow fever. But then the history is against it, because I mean, yellow fever, at least in our setting currently, is not. Uh, we do not have epidemic levels of yellow fever. So, but viral hemorrhagic fevers, the commonest one is dengue fever. So, and dengue can affect the liver. So, uh, that's another possibility. But then these are just, those are random thoughts about systemic processes that can involve the liver. So, those are some possibilities. And then apart from those, the acute hepatitis drugs, we've already excluded them because the patient is not on any drugs. So I assume that it's for prescription drugs over the counter as well as herbal medications. The patient is not on any. And then we can think of hepatitis from alcohol. This patient doesn't use alcohol. He doesn't use any illicit drugs. So an acute hepatitis from drugs or toxins of any other kind, I think we've excluded them. So we are thinking most likely probably an infection. So yeah, that's where I am right now. I'm thinking I'm biased more toward an acute hepatitis, and I've discussed other organisms, but then if I leave those other organisms, I should mention the ones that can cause hepatitis, and these are hepatotropic viruses. Hepatitis A, hepatitis B and C commonly. So the hepatitis B and C can be sexually transmitted. We are told he has one sexual partner, I mean, with an inconsistent history of using condoms. So could be a possibility. But then with hepatitis A, uh, which is predominantly through fecal transmission, it is a possibility. But then I think commonly with hepatitis A, we see the gastrointestinal symptoms like diarrhea, and then later on you have the icterus. But so these are some possibilities. Maybe labs will help me clarify my thoughts more.
Yeah. Very nice. So maybe one thing, jaundice is very, very common problem that we see in internal medicine, and I can hear you are mentioning a lot of good differential diagnosis. Do you happen to have any approach that helps you think about those things?
Can you come again, Joseph? I'm not sure if it's my internet or if it's yours.
Oh, I was saying, can you hear me?
Still breaking.
Oh, okay. I think it's your internet. Can everyone else hear me?
I'm not sure about everyone else. Maybe let's see. Is everyone else hearing Joseph clearly?
No, there is breaks in his speech.
Okay. How about that?
Can you try again? Clear.
Okay. I
I
was
hope it remains the same.
I was saying jaundice is one of the very common problems in internal medicine, and you have been mentioning
Still,
very good differential diagnosis.
uh, I haven't heard you clearly. You are still breaking. Can
Okay.
you find a way around your internet?
Maybe let's proceed, and when the internet comes, it becomes stable. I can ask you my question, but let me give you
Okay, no problem.
no problem. Okay. Maybe the internet doesn't want me to ask the question. Can you see the slide for labs?
Not yet. Yes,
Okay.
seen now.
Yeah, so these are the labs of this patient. He had a white count of 12.8, which was raised. Absolute neutrophil count was also raised at 8.6. Other differentials were normal. HB was 13.6, platelet 305, MRDT was negative, H. pylori stool was also negative. His creatinine was 99.7, which is normal. The BUN was 2.6, albumin was 38, serum amylase was 63, which is also normal. His transaminases were all raised. ALT was 226, AST was 129, the ALP was 149, the GGT was 188, total bilirubin 58, direct bilirubin 26, the PT, APTT, and the INR were normal. Hepatitis B and C were negative. This is the abdominal ultrasound. So it showed a normally sized liver at 14 centimeter with a bright echogenic dots throughout, which the radiographer described as starry sky appearance of the liver. He also had excessive bowel gases in the epigastric region, but other parameters were normal.
Okay, now that you are clear, can you ask the question that you were asking?
Okay, my question was on differential diagnosis of jaundice. I said jaundice is one of the most common problems in internal medicine, and that you have been mentioning very good differential diagnosis. So I was wondering if you had an approach in your mind that you use to come up with those differential diagnoses.
Well, so jaundice, I mean, and the differentials that I've been mentioning were based on this patient's presentation, but then the way I approach jaundice generally is the same way. I believe almost everyone does the same ways. Think of jaundice in terms of, as pre-hepatic, hepatic, and post-hepatic jaundice. And so for pre-hepatic, you are talking about hemolysis most commonly. And then with hepatic, you are talking about a primary problem in the liver. And then post-hepatic is when you are talking of cholestasis of any kind, whether it's obstructive or non-obstructive. But then, so for this particular patient, I based more on hepatic jaundice because of the history that we had, that the patient is presenting with abdominal pain and then there is tenderness in the right upper quadrant. So I mean, if it was pre-hepatic, we wouldn't expect to have a picture that is suggestive of hepatitis. And then if it was post-hepatic again, most likely we wouldn't have a picture in keeping with hepatitis. So the fact that there was tenderness in the right upper quadrant, it made me lean in the direction of that we are dealing with hepatitis. And then labs are proving that we are dealing with hepatitis. So we see a leukocytosis with the predominance of neutrophils. So we have predominantly neutrophilic leukocytosis. Other parameters are normal. So I mentioned a number of organisms that can present this way, but then if you are talking of viral hemorrhagic fevers, for example, presenting with a picture of hepatitis. So in that case, you would be talking, for example, if I'm talking of jaundice, you would be talking of, if I was talking about dengue, then you would be talking about dengue with warning signs. And for that matter, commonly you would expect to have a low platelet count, which you do not see in this patient. Now, neutrophilia and the leukocytosis in general is not very helpful in making progress. It just tells us that we have some kind of inflammation, infections being one of them. And commonly when we see neutrophils, we say most likely it's a bacterial infection, but then anything can cause leukocytosis with the neutrophilia. So I do not think it helps me make a lot of progress. And then when we come to the liver enzymes and the liver function test, we see that there is a picture of transaminitis. So you have the ALT elevated more than, this is, I believe, almost 4, 5, or 6 times the upper limit of normal. And then the EST is also elevated. And markers of cholestasis are also elevated, ALP and GGT. And then there is hyperbilirubinemia, which seems to be predominantly, it's almost half. So 26 over 58, almost half. So the yes, so indirect bilirubin, or the indirect bilirubin predominates here, because if I take 58 minus 26, that is 32. So you have an indirect hyperbilirubinemia. But then even with this elevation in direct bilirubin, it's not very surprising, because even with hepatitis, you can have intrahepatic cholestasis, and therefore you could have a picture that can confuse you that we are probably dealing with an obstructive picture, but it's just intrahepatic cholestasis. So all these are telling me that we are dealing with an acute hepatitis. Now, what is the cause of the hepatitis? Hepatitis B surface antigen is negative. This does not help me rule out acute hepatitis B infection, because if you are talking of an acute infection, I mean, yes, the hepatitis B surface antigen, because yes, with antibodies, I mean, that wouldn't help rule out, but then hepatitis B surface antigen, it's likely that we are not dealing with acute hepatitis B infection, because with an antigen, as long as the organism is present, we should have been able to pick the antigen. But then with antibodies take some time. Antibodies take some time for the titers to rise, to rise enough to be picked, and therefore ruling out hepatitis based on that antibody, I'm not sure. But then again, epidemiologically speaking, hepatitis C is not as common as hepatitis B in our setting. So I would still consider it, but wouldn't be too much worried about it. So now the question is, what is causing the hepatitis in this patient? That's the question. And then, can I see the slide on imaging? Okay, so normal size the liver, but then there are bright echogenic dots throughout, starry sky appearance, and then excessive bowel gases. Other parameters were normal. Yeah, so I should say I do not know what the starry sky appearance means. I remember hearing about that term just once, and I think that is when we were talking about. I think we were discussing about something about schistosomiasis, but then uh, I haven't read in details about it, so I'm not exactly sure what a starry sky appearance in the liver would mean. But then the bright echogenic dots throughout maybe will just tell me, so there is patch inflammation that is going on. Otherwise, I'm not sure if it's something that leads me in the direction of the diagnosis. Yeah, so is there anything else?
Okay. Um, Maybe from you. Do you think is there any lab or anything that can help you navigate further in the direction of diagnosis?
Okay, so for this patient, I should try and represent this problem. So we are dealing with a 21 years old male with an unremarkable past medical history who presented with a 7 days history of abdominal pain and 3 days of fever. Abdominal pain in the right upper quadrant, trying to be specific. And then he also presented with uh, fevers and night sweats. He had night sweats, but then no weight loss. He had a nausea, but no vomiting or diarrhea. The review of systems was unremarkable. And then the patient is not on any medications. He doesn't use any substances. Physical examination, right upper quadrant tenderness. He is febrile and jaundiced. And coming to labs, we see a picture of, we see a hepatic picture, a mixed hepatic and cholestatic picture with an elevation of transaminases as well as ALP and GGT, with a predominantly indirect hyperbilirubinemia and a leukocytosis. Hepatitis B and C negative. So yes, I would need some other labs. So for example, hepatitis A, checking for hepatitis A, and then what else? Also, yes, I mean, this is a very acute thing, but I should say HIV is something. I mean, HIV can present anyway. So I'll do also HIV serology just in case. But then, if we were talking about an acute infection, I mean, if I recollect properly, acute HIV infection can present with a picture of hepatitis, but then that will be some weeks down the line. Since an infection, you are talking about 4-6 weeks or something. Uh, so, and there says that we have, I think, the kits that we have are third generation, and therefore you will be able to pick the antibodies in about a month or so. So if we are dealing with an acute infection, maybe not likely to pick it. But then, so something else, the patient presented with fevers and night sweats, and we are in a TB endemic area. So I should throw in tuberculosis as one of my differentials, but then the patient didn't have respiratory symptoms. He did not have respiratory symptoms. So uh, coming to labs now, I mean, if there was any other lab that would help me rule out tuberculosis, for this particular case, a picture of hepatitis, I can't see any samples to take. So, I mean, yes, it would be convincing to go for serum ADA, but then serum ADA, uh, in my opinion, is not very specific, or yes, is not specific enough to rule out or to try to rule in or rule out tuberculosis, serum ADA. But then if you are talking about a pleural fluid or acidic fluid ADA, I would go for that. But this patient doesn't have those. So any other lab? I mean, apart from hepatitis A, apart from HIV, what else? I mentioned some other differentials, but then uh, dengue serology. I mean, the possibility of dengue in this patient is low, but I'll do it. I'll do dengue serology, and then leptospirosis. I mean, if this patient, and we do not have, I'm assuming it wasn't a time of, it's not a common infection in our setting. We just had a few outbreaks. I think we remember that outbreak, and therefore, epidemiologically speaking, I'm not very much convinced that that is the possibility. So, I mean, those are a few ones. I can't think of any others right now.
Okay. So hope you get some that you asked. And hepatitis B, hepatitis A, IgM antibody came back negative.
Okay. Do we have anything else?
I think you can discuss here. So if it's negative, what are you? How are you progressing?
Okay, so this patient has been sick for about a week. Yes, because the abdominal pain started. Uh, the patient presented about a week after onset of abdominal pain, and then
Joseph, your
fever,
internet is still sick.
and then fever came later. So, I mean, within 7 days, I believe at least IgM antibodies would have been positive. So the fact that IgM antibodies are negative, the possibility that we are dealing with hepatitis A is low. So what else is causing a picture of acute hepatitis in this patient? Because all hepatotropic viruses, to some extent, we've ruled them out. Hepatitis A, B, and C. So I mentioned the other things I mentioned about just based on the night sweats, but then people can present with fevers and night sweats from anything. But then I just because we are living in a TB endemic area, I think we should consider tuberculosis. But then in this particular patient, I do not see a better way to establish that diagnosis. And then the other viruses that I mentioned about to begin with, the possibility is low. So, yeah, I mean, at this point, I think I should think what are the other causes of acute hepatitis? Uh, the other causes of acute hepatitis that we haven't talked about so far. So, we talk of acute hepatitis, there are infections, and most of them we've talked about. So, the rest are like Epstein-Barr virus. CMV can also cause that, and then we also have protozoa infections like I mean, amoebiasis, we talk about amoebic liver abscess, but then it can present with hepatitis. And then, I'm not sure. I mean, I'm not sure where this patient is located. I'm not sure where this patient is located, but then if it is somewhere where schistosomiasis is endemic, then we should also think about schistosomiasis, especially the intestinal pathogens, Schistosoma mansoni. Yes, because those ones can affect the biliary system. So the cholestatic picture that we see, so that could be a possibility. But then, could they explain the night sweats? I do not think so. And then Salmonella typhi, so typhoid fever, not very common to present with hepatitis. And then, so I've been talking about infections so far. What are drugs? We've ruled them out. So acute hepatitis due to drugs, this patient is not on any drugs. So let's consider another possibility, which is autoimmune disease now. This patient in the history did not have any pointers of an autoimmune process. But then, yes, you can have autoimmune hepatitis. I mean, isolated autoimmune hepatitis. But then, autoimmune hepatitis is more common in females compared to males, just like other autoimmune diseases, if I remember correctly. Yeah. So, but then, so can I consider autoimmune hepatitis in this patient if I test all infections and all other causes of hepatitis and they come back negative? Then I'll make a bet and test about autoantibodies that can tell us about autoimmune hepatitis, like antimitochondrial antibodies, anti-smooth muscle antibodies, and see how it turns out. But then epidemiologically, the possibility is low about autoimmune hepatitis. And uh, amongst all autoimmune diseases, I think autoimmune hepatitis uh, is the most reasonable to consider here and not others. Yeah, so I'm prioritizing infections, but then apart from infections, the other possibilities, we are dealing with something autoimmune. But then I'm ready to be surprised. Let's see where this went.
Yeah. So, like you, I was considering the same possibilities, and in going back and forth with the patient and reading around, I questioned him if he said he's not on any meds. How about other maybe herbs? And yes, he told me he has been using herbal remedies for erectile dysfunction that he purchased online, and he started using them 3 weeks ago. So I wonder, does this help you in any way, or maybe it's just a red herring that is there, and then you are still considering those diagnoses that you're saying?
Well, so I mean, we are dealing with a healthy 21 years old male with an unremarkable past medical history. Uh, so this history, I wouldn't take it as a red herring. I mean, I at this point, I consider a huge possibility that we are dealing with a drug-induced liver injury. So we excluded hepatitis from drugs because the patient told us he's not using any medications, and we made an assumption that he wasn't on any prescription medications, over the counter or herbal medications. But then with the history that the patient has been using herbal medications 3 weeks ago, that raises the possibility that we're dealing with a drug-induced liver injury. So I think that's my diagnosis at this point.
Do you think this can explain the fever, especially the fever?
Okay, so I mean, that's a good question. The hepatitis explaining the fever. It could be because fever is a non-specific complaint, and fever is just endogenous pyrogens rising. So that comes from inflammation. Fever comes from inflammation, and I mean hepatitis is inflammation. So yes, drug-induced liver injury. We see a picture of hepatitis, the fever. It could explain the fever.
Sure.
So given the fact that we've tested the commonest viruses or organisms in general that could lead to this presentation, and they are negative, and then we hear recent history of herbal medication use, most likely we are dealing with a drug-induced liver injury.
Sure. Yeah, that's is in line. And I'll tell you one thing that happened, and I want you to what you do have done. So I was asked. This patient has a fever, and the nurse is nurses they don't like to see fever. So what are you doing with the fever
Yeah.
at this point?
Okay. So yeah. So with this fever, okay, the patient has a high grade fever. I mean, the fever is 39 point.
Yeah.
So it's uncomfortable for the patient. So it's okay to give antipyretics, but then I mean, with the acute hepatitis picture, someone should avoid paracetamol.
Sure. So
Yeah.
what do you give?
Okay. So the other options that we have, I do not think NSAIDs hurt the liver as much as paracetamol do in the setting of acute hepatitis. So, but then because I'm not exactly sure, I'll definitely need to check first. So I'll either check on up to date or Medscape to see if it's safe to give something like an injection of diclofenac in this patient.
No, no. So I think your diagnosis is drug-induced liver injury.
Yes.
Yeah. So very nice. I was thinking like you, and because patient was admitted in the ward, so I was going back and forth home reading and trying to see what is happening. And yes, drug-induced liver injury. After we excluded other possible diagnosis, and then at the end he told me that he was using some herbs, and I considered it. And when the subject is herbs now, you call it herb-induced liver injury. But again, you can't rule out other diagnoses, especially autoimmune hepatitis, as you were alluding to. But again, a drug can cause a drug-induced autoimmune hepatitis. A drug itself causing autoimmune hepatitis, which is not idiopathic, meaning that when you remove the drug and you give some steroid, a short course of steroid, patient comes back to normal, as opposed to autoimmune hepatitis, which you would need to give an extended steroids. So, as we all know, drug-induced liver injury or herb-induced liver injury, this is a diagnosis of exclusion. That's why we are going back and forth, me and David here. And yes, David, truly, to diagnose autoimmune hepatitis, you need the antibodies. The first one you should do the ASMA and ANA. But at the end, if we had everything in this patient, which we don't know now, autoimmune hepatitis or herb-induced liver injury, you have to do a biopsy. So I discussed this possibility with the patient and the family, and I told them, after the hepatitis A came back negative, I told them, at this point, we have to send you somewhere to do a liver biopsy, because if it is truly autoimmune hepatitis, it will recur later. But the family and the patient said, no, let this patient stop what he was using, and then we go home and see later. If it goes on, will go to that liver biopsy? I say yes, it's up to him. And as you, David, very nice. I had to use now the epidemiological approach to consider autoimmune hepatitis vis-a-vis herb-induced liver injury. And truly, autoimmune hepatitis, as many other autoimmune diseases, more common in females. The type 1 autoimmune hepatitis, 4 times more common, while the type 2, 10 times more common. The types are just which antibodies are in which type. I didn't even memorize them because they're not important at this point. So, concerning the fever, when I was reading, I realized I should avoid paracetamol and other NSAIDs. I had a chance because it was written when this patient with DILI or HEALY, they come up with fever, is, as you're saying, because they are having inflammatory reactions. You give them prednisone. So yes, I gave the patient prednisone 50 milligram or D with plans to taper, and on the next day, fever, abdominal pain, they went away. So I instructed the patient to taper the steroid the next day, but he only used them for 1 week and he stopped. So when I communicated with the patient later and realized he was well and he just used 1 week, 1 week prednisone, I realized this can't be autoimmune hepatitis because that was the point that it had to come back very strongly. So he stopped his herbal remedy, and I told him he has to attend the erectile dysfunction clinic. And I had no recurrent of symptoms on stopping the steroids. The transaminases, went trending down, starting in the ward, and then when he went home, and then after 2 months, they went back to normal. So that's where I was, and I have some learning points for everyone here. So, people consider herbs to be natural and they think they are safe. And I read the literature around it is said even in this country we have this thing. People consider herbs to be more safer compared to prescribed medications. And this problem is compounded by being unregulated. They're not regulated, that these patients purchase them on the internet. So the herb-induced liver injury and the drug-induced liver injury is just the same thing except which is causing the disease. Even the management approach is the same. So it is crucial for clinicians to inquire about herbs when seeing acute hepatitis in patients. For example, in this patient initially, he didn't tell us if he used, but when we questioned him, maybe he didn't even consider when herbs can do this. And you'll be surprised. He traveled from where he came from to the hospital with the meds that was using. So yes, when you're describing drug-induced liver injury or herb-induced liver injury, you divide them into intrinsic or idiosyncratic. Intrinsic is the one which is predictable. For example, you know that if you ingest 10 grams of paracetamol, what will happen. But idiosyncratic, you cannot do that. For example, in this herb, that maybe many people use this herb and they've never had hepatitis, and this patient is having the hepatitis. We use the R value to tell the pattern of liver injury, whether it is hepatocellular or cholestatic. So what you do, you take the ALT and you divide by the upper limit of normal of the ALT. And the answer of that, you divide to the ALP, divide by upper limit of normal of that ALP. The importance of this is once you get it, there are other differential diagnoses that you put up and some you put down. So if the number comes back to be above 5, you know that is hepatocellular pattern of liver injury. When it is below 2, that is cholestatic. This patient had a mixed pattern. It was the other values for. So yes, withdrawal of the offending agent is the cornerstone of management. There is limited evidence for the role of steroid in drug-induced liver injury, and this is from the American College of Gastroenterology. But it may be used in drug-induced liver injury with hypersensitivity features or biopsy results that are resembling autoimmune hepatitis. So that's why I use it in these patients because of that, especially the fever. Yeah, so that's where we are. If you have any reflections, David.
Well, I think it's quite evident. I do not have a lot of words today. I mean, uh, I think every day it becomes clearer to me how much of a difficult job we are doing. I mean,
So,
it's hepatitis, someone presenting with abdominal pain, fever, and then you pick jaundice. But then picking the cause of this acute hepatitis took a lot of effort. And I mean, yes, and our patients sometimes do not volunteer information that we desperately need in order to make a diagnosis. Until you spend a lot of time, you spend a lot of resources, because I think if the patient had volunteered that information early on, then testing wouldn't. I mean, yes, some of the basic investigations would have been done, but then I believe diagnosis would have been made earlier. So yes, it's a huge learning opportunity for us. It just reminds us that the diagnostic process is difficult, and I think everyday practice is very necessary in order to achieve mastery, if at all we'll be able to achieve that.
yeah.
Yeah, so thank you very much for this great case. I mean, it's hepatitis, but then it made me sweat and blood.
No, you didn't sweat, my friend. You had it from the moment you started. So one thing, Starry Sky appearance, yes, yeah. I then did in MD2, and then I saw the report and say, what is this? I looked it up. It is non-specific. It all means there is inflammation of the liver.
Okay.
Yeah.
Yeah, thank you very much for the good case. So I see we have a lot of attendees today. So some have already left, but then we are still remaining with a good number. So I welcome the floor if there are any comments, any learning that you would like to share with us. Karibu sana.
Yeah, hello.
Hello, Emmanuel.
Hello, karibu. Karibu
Yeah,
Emmanuel.
yeah. Thank you for this presentation. I think it has added some new knowledge. I never knew the drug-induced liver injury would have this kind of presentation, like the abdominal pain, the jaundice. But I just have I don't know if it's a comment or a question. The erectile dysfunction, because I see this patient was using herbal medication for quite some time. Were the herbal medication helping with the erectile dysfunction? And is it just an incidental, or it had some value in the differential diagnosis of the patient? I
Yeah,
don't,
thank you,
yeah.
Emmanuel. Thank you very much. That's a nice question. First of all, there is a guy here, a very nice doctor called Kazaura. You speak like Kazaura. Sauti ya Kazaura.
Okay.
Yeah, so I didn't delve much whether the herbs helped in his erectile dysfunction, but what I told him is to stop them. And when he stopped them and the disease went away, I realized this the medication that caused this, nothing else. But I guess maybe I should have considered if it is helping. I was not interested.
And but then there's something like I think it's one of those areas where there is a lot of misinformation. He's 21 years old,
Yeah.
healthy. We didn't hear about any chronic illnesses or anything. So I mean, the first question really is whether the patient has erectile dysfunction, real erectile dysfunction, or it's perceived. based on popular opinion online. So I think it's probably one of those things that will we do not encounter many times because they end up being treated by street doctors who have their remedies.
Yeah.
But then I think when things turn around, like in this patient, that's when we get to see them. But then uh, I, I mean, I do not have data. But then I should say, I think the problem of erectile dysfunction, or I mean, especially among young patients, I can't speak much about older patients with comorbidities, but then among young patients, I think it's overrated.
Mm-hmm.
Okay.
So you find, yeah, many of them do not have any problem, but then based on popular opinion, I mean, things that they hear online, and then maybe things that they discuss with friends, they think something is wrong with them while nothing is wrong. So we are not sure in the first place if this patient had erectile dysfunction really.
Okay. Thank you.
Yes, I see a hand from David. Karibu.
Okay, I think you raised it accidentally.
Okay, is there anyone else with any comment, any question, anything you'd like to share with us?
No many
Okay,
questions today.
yeah, I see people. I'm not sure if it's contemplation or yeah, but people are very quiet today. But then I see some new names here. We have I see we have Happy. Happy, do you mind unmuting yourself and saying hi?
Hi, thank you. It was a very good presentation.
Karibu.
Thank you very much for joining. Do you mind telling us where you are joining us from?
I am joining you from Qatar.
Oh, awesome.
Yes.
Uh, Karibu sana. So we are here every weekend. I believe you'll keep joining us.
I hope so.
Karibu sana.
Asante.
Alex, karibu.
So, David,
Yes, Alex.
thank you for the discussion, and Joseph, thank you for the case always. I really appreciate your hard work in trying to compile these cases. Uh, they, I have no comment on the case, but I'm interested with the story of Hebels. I don't know if you guys get these questions nowadays. I get them almost every week. Like, daktari, kuna dawa ya kienyeji sijui, those stories. I think, as Joseph said, people still think that herbal medications non-toxic completely. So we have a challenge of trying to educate these clients of ours because I have a sad story of a client I made when I was working as a GP in there. This patient had a lot of money, was a good businessman, had hypertension, and then he came at a clinic where I used to work, talked to him about starting medication, checked all his uh, target organs, they were fine, the heart, the kidneys, the liver were fine. And then he said, no, I can't start all the medications because they are lifetime medications. And then he said he's going somewhere. And when he came back, he was toxic, swollen, breathing with difficulties, and checking the kidneys were gone. And I asked him, what happened? He said, I went to the village and there I found a doctor who gave me the medication for the blood pressure. So it ended to be the blood pressure medication was a toxin to the kidney. So he got kidney injury. And then I told him, now at the stage you are, there's nothing we can do with your kidney now. You need to go into emergency dialysis. So he did the around 5 dialysis sessions. He was a Kinga man. So you know Kinga with money. If you tell them to pay money in the hospital, they feel like you are taking their money for free. So he said, yeah, no. And then after 5 sessions, he went away, stayed 1 month, came back critically ill. Did 3 sessions, unfortunately, he passed away. So that is the story of herbal medication I met in my practicing career. So I think we need to put a great effort to just warn these clients because those who sell them, they try to say, to tell them that this thing is non-toxic and it's fine. Maybe it has worked with someone and it was not toxic, but I still believe the story of single nucleotide polymorphism could be applied also to local herbs. So I think we need to caution and be careful with them. I get these stories every week. One client would ask me, daktari, kuna dawa nasikia sijui ya kienyeji, but my answer is always mimi sijasomea dawa za kienyeji, so siwezi kuelezea hilo, ila ningekushauri tu uzingatie za hospitali. I try to give that answer always. So let's be just to remind ourselves on counseling on the importance of adhering to medical to the drugs that are from the industry, which we have studied well and we know them, but with the local herbs, yeah, there are some risks, and like that's the story of my client. Thank you, Joseph, for reminding us the story that they are not toxin free boss.
Yeah.
Asante sana.
Karibu.
Thank you very much, Alex. I think, yeah, that's a good reminder. I mean, it's a question that I believe many of us get, and so whenever I get a question like that one, of course, my answer is always the same. So we are not exactly sure. I mean, and what exactly is the dose that you are taking? There is no standard dose for most of those medications. Do you take a spoon, or do you take a cup, or do you take a gallon? What exactly? So I think that should be the message, that just because it's called herbal, or just because you are told it's natural, doesn't mean it's completely safe. So as long as we say it's healing something, then that means they are active ingredients, and therefore it's a drug basically.
Sure.
Yeah, so I think that's a good reminder, and a very unfortunate story about your patient, Alex. So I believe we should keep educating our patients, and hopefully save them from unfortunate stories like these ones.
Oh.
Okay, so I see we do not have many issues today. Joseph, on your side, anything?
maybe for the people here, I still encourage again, if you happen to have any case that you think is interesting, you can share with us. You can come and present it here. It doesn't need to be complicated, any case. And it doesn't need to have all the answers. We can work it together here. Just check one of us,
Yeah, sure.
David or me, we can arrange for you to present it. As an unknown, by the way.
Yeah, sure. Yeah, I think we should start doing that. And then from next week on, I hope we'll get volunteers. So at least if Joseph is presenting a case and I'm discussing, I'm looking forward to get a co-discussant. We'll be discussing together. So I think let's try and make this more inclusive. So anyone who is willing to volunteer, just you can let me know beforehand, or when we start the session, you can just volunteer and discuss with me. That will be a lot of fun.
I,
Yeah. So if there are no other issues, then we had Msabi today. I'm not sure if you are still around. If you are around before we close the session, unaweza kutusalimia.
I think he left.
Are you there?
No, I don't think it is there.
Then Msabi. Right. Probably they in a place where they can speak.
Yeah,
So thank you everyone for joining. We hope to see you again next weekend. We'll communicate early before time, the
Hello,
day and
doctor.
time and the link as always. Hey, karibu Msabi, mambo yanaendaje ese?
Yeah, thank you, bro. I'm doing fine. It has been a long. Hello,
Mse, karibu sana.
hello. Yeah, thank you for a good
Yes, karibu.
presentation. Yeah. Hello.
And thank you very much
Yeah, it has been
for
a
being
good.
around.
Yeah, thank you. Hello.
yes, Msabi, we
Yes,
have heard
hello.
you. Thank you very much.
Okay, so yeah, so next weekend we'll share the link. So again, share it widely. We had a number of new people joining us today, but then some, I think they left before closing. But then the attendance was good today. I think it was over 40 people at the beginning.
Yeah,
So some left in the middle, but then I think we had a very good attendance today. So let's keep inviting more people and let's learn together. So good night, everyone.
good night.